afternoon for our friends on the eastern side of the country, and good morning for our friends a little further west. Welcome to this week's Systems for Action Research in Progress webinar. My name is Anna Hoover. I am co-director of the Systems for Action National Coordinating Center at the University of Kentucky, and it is my pleasure to be your moderator for the next hour. And we're going to hear about some exciting new research through this still fairly new national program of the Robert Wood Johnson Foundation. We are going to get into some details about both the National Program of Systems for Action and its structure before we talk too much about the specific research project, but I do want to cover a few housekeeping items for right now and remind folks first and foremost that as we move through today's webinar on a community complex care response team to help improve geriatric public health outcomes, that as questions arise, you do have a chat box on your computer. If you are watching, if you're joining us for the web portion of this webinar, there is a chat box. Please feel free to ask your questions as they arise. Sometimes we think, as someone is speaking, oh, I want to know about that, and by the end of the call, we've forgotten our question. So please do be writing your questions into that chat box as we move through today's Research in Progress webinar. Just, I think everyone on the line likely knows the topic you're here for, but just to remind folks, we are hearing about the Battle Creek Community Complex Care Response Team to improve geriatric public health outcomes. It is an individual research project recently funded through the Systems for Action National Program Office. We'll be hearing from Carolyn Pickering, an assistant professor in the School of Nursing at the University of Texas Health Science Center at San Antonio. And then we'll be having some commentary from Ruth Coffman, who is the Executive Director of Health Lab at the University of Chicago Urban Labs, which is one of our collaborating research centers in the Systems for Action National Program. We're going to talk a little bit about what that means in just a moment. After we hear from those folks, we will have time for questions and discussions, which is why, again, I've asked you to remember to be putting those questions in as we move through today's program. For those of you who are new to the Systems for Action National Program, I want to give you a little bit of background about that. It has arisen and is building upon prior work done through the Public Health Services and Systems Research National Program of the Robert Wood Johnson Foundation, as well as health services research. As the Robert Wood Johnson Foundation has been thinking about multi-sectoral collaborations that can really improve health in this country and generate a culture of health across the nation, it's become more and more important that we widen the lens of public health services and systems research and of health services research to really consider the other delivery and financing systems that contribute to health in the United States, including the usual suspects of medical care and public health, but also looking at the social and community services that can really help improve not only health but also well-being. And we're supporting through this program rigorous research that helps us achieve efficiencies in resource use and reduce inequities. By aligning these delivery and financing systems, we're really looking at a number of sectors through this. And if you haven't had an opportunity to read the research agenda on the Systems for Action website, please take some time to do that, as it delves in much more depth than I'm going to be able to talk about in this first couple of minutes into what some of the gaps are, what some of the areas that this program is really interested in investigating, how we can better align and integrate these systems are. But just to give you an idea of some of the sectors involved, beyond public health and medical care, we're also looking at things like income support, nutrition and food security, education and workforce development, housing, transportation, criminal justice, child and family services, and community development and finance. These sectors work often with vulnerable populations in parallel sometimes, and are sometimes often siloed from the public health and medical care sectors that think of themselves as concerned with health. So how can we produce rigorous research that really investigates the best mechanisms for aligning these systems and reducing inefficiencies and improving outcomes. We're looking at a number of novel mechanisms for how we might align systems and services across sectors. You see a list here. Again, this is elucidated in much more depth in the research agenda, and I do encourage you to have a look at that. We look at everything from alliances and partnerships to information exchange to governance and decision making and community engagement, values, and workforce and staffing models. So there are a variety of different mechanisms that are being explored across the country for better aligning and integrating these systems that contribute to a culture of health. So we really want to think about how best, what are the pieces that are working, and we're really looking for research that is exploring that in great depth and with great rigor. I want to give you a little bit of background about the Systems for Action National Program Structure. As you can see here, we at the University of Kentucky are the National Coordinating Center, and we have been charged with the development and maintenance of things like the research agenda and the general structure for the program, working in close consultation with the Robert Wood Johnson Foundation. So we work closely with 3 collaborating research centers that were funded earlier this year. Each of these collaborating research centers has its own set of research focus and expertise that it is bringing to the table. We have partners in CRCs at the University of Chicago. Again, we'll be hearing from Ruth Coffman a little later with that particular CRC. We also have collaborators at Arizona State University and at Indiana University, Purdue University, Indianapolis. As we go through these webinars describing individual research projects and collaborating research centers, we hope you'll get to know more and more about these centers, the work they're doing, and how they can interface either with research you're doing if you're a researcher, or with practice if you're working in one of these delivery system areas. We also have recently funded 4 individual research projects through this national program. Today's presentation is about one of those. I'll share a little more about the individual research projects in just a moment, but first, just a little background on those collaborating research centers. You can see here what each research center is focusing on right now. At Chicago, they're looking at a randomized trial of comprehensive care, community, and culture. Arizona State is looking at an analysis of medical, mental health, and the criminal justice system interactions for persons with behavioral health disorders. IUPUI is looking at evaluating the integration and decision support strategies that really support a community-based safety net healthcare and public health system. And finally, in our intramural research portfolio here at the University of Kentucky, we're looking at measuring multi-sector contributions to public health services and population health outcomes. These individual research projects, for those of you who have been playing along at home on this webinar series, you know that last week's webinar was really highlighting the first of these, and that is the University of Delaware. If you go down 3 in the bullet list, our first webinar really looking at one of these S4A, as we call it, individual research projects. Today we're going to be hearing from our friends at Michigan State University and University of Texas, talking about this community complex care and response team. And we will be hearing in future webinars from the Los Angeles Department of Health and from Drexel University. If you missed that Delaware call last week, it has been archived online, so please spend some time on the S4A website, and you can find your way there. And if you can't, let us know. We'll send you a link directly. I will say, for those of you who are going to be asking about today's call, it will be archived as well. We'll also be sending out the slides to everyone who is registered for this call. We know that there's always a high interest in folks having a look at slides, so those will be going out to everyone registered after the call. And we will keep you on our mailing list and keep sending you information about what's on tap for the next call. So with that bit of background, I'm going to hand the mic over now to our presenter for today, Carolyn Pickering, who is an assistant professor in the School of Nursing, Department of Health Restoration and Care Systems Management at the University of Texas Health Science Center in San Antonio. Carolyn?
Hi, Hi, good morning or afternoon, depending where you are. So I'm going to be telling you about our project, the Battle Creek Community Complex Care Response Team, which I'm going to abbreviate to CCR during this presentation. So as mentioned, I'm at the School of Nursing at the University of Texas Health Science Center, San Antonio, and I'm one member of our interdisciplinary research team, which includes Christopher Maxwell at Michigan State University School of Criminal Justice, and Fouad Aboujarad, who is our health IT computer scientist expert at Yale University Department of Emergency Medicine. So our project is rooted really in elder abuse and neglect. Elder abuse and neglect is an act of harm or a failure to provide services to an older adult. And the actual elder abuse and neglect, I suppose, statutes and legal definitions vary by states. So some states like Texas, this is an act of harm or failure towards anyone age 65 or older. And states like Michigan, it's actually based on a vulnerability. So it's against act of harm or failure to provide services to a vulnerable older adult. And that's an important distinction somewhat because we're really targeting vulnerable older adults in this intervention. The elder abuse literature and science in whole has been a slow-growing science because there's a lot of barriers to doing research on this topic. But according to our best available evidence, 11.4% of older adults in the community have reported a past year prevalence of abuse and neglect. That's an extraordinarily high number, in my opinion. Victims experience a lot of poor outcomes, including physical injuries, mental health problems, financial strain, disrupted relationships, a 300% increased risk of mortality. Elder financial abuse alone cost victims an estimated $2.9 billion in 2010. And so that's just financial abuse, and that's just the cost of victims. The cost to society, with all the other types of abuse rolled in, it's got to be much, much higher than that. Despite all this, there's currently no rigorously tested interventions either to prevent abuse and neglect or help victims. Which is how this project kind of got going. So this is the framework that underpins our care model intervention that I'm going to be talking about today. It suggests that caregiving and relationship outcomes such as quality of care, abuse and neglect, symptom management, etc., is a result of an interdependent dyadic relationship between an older adult and an informal caregiver. Each member has their own different vulnerability and risk profile, which impacts that role interdependency and the relationship dynamics, and therefore the outcomes. So, in our community complex care response team care model, the goal of the model intervention is to decrease vulnerability of older adults by promoting and supporting independence and capacity for self-care. And we hypothesize by doing this, by decreasing that vulnerability, we're going to impact the relationship dynamics, that interdependency, by hopefully reducing it, and therefore preventing and reducing opportunities for abuse and neglect and poor care to occur. So the idea behind the care model, I guess pragmatically speaking, is that by working together through a care model based on shared communication and information exchange, that the various agencies in Battle Creek that provide services to older adults can maximize service resource availability for clients, as well as maximize resources within the agency. So I want to give you some project background because I think it's important to understand how we got to where we were. This is really a community-based project. It started with, in 2012, with funding from the Office of Violence Against Women, Calhoun County, which is the county that Battle Creek is based in, worked together and formed the Elder Abuse Prevention Network. And part of this prevention network and this Elder Abuse Coalition and the task under this grant was to identify, the needs in better responding to elder abuse and neglect and problem solve about how to do this. And so the group identified the need to share information between health and human service agencies in order to better assist victims. And so the problem solving led to developing a uniform consent form that would allow for sharing of protected health information and other confidential service data between the agencies. so that they can work together to deliver services. And this informal coordinated community response team emerged. I say informal because it was a small group and they all worked together, but we hadn't set yet real protocols for how the coordination was going to work. That all started to come in 2015 with funding from the Hartford Action Award program. With funding from this group, we were able to formalize the CCR model protocol for coordinated case management, set some structure to who does the intake and what happens next, etc. With that, we also developed an electronic case management system, and this is really important. This is how the platform for how we're doing the care coordination. This platform allows the different agencies that are involved on the team to be able to share the information, to speak with each other, engage in shared decision making, respond with updated information, etc. During this project, we developed and then piloted it along with this new model protocol and the uniform consent form. During this pilot, we were able to expand our stakeholders. We had interest and support from other agencies in the community. And with that expansion, we expanded our initials and became the CCCRT, our complex care response team, because now it was more than just coordination, but also really looking at responding to the needs of people in the community. And shifting our focus from just service delivery for victims to really prevention and service delivery to all vulnerable older adults. So now with the Robert Wood Johnson Systems for Action program, we're able to implement an RCT to evaluate the impact of the CCR care model as a primary prevention strategy. So briefly, let me introduce our project stakeholders and partners. So there's two components to this. There are agencies that are our referral partners, and these are the agencies that identify the potentially vulnerable older adults who may benefit from the intervention. And this includes the Battle Creek Police Department, the Bronson Health System Emergency Department, who is the regional emergency department, and then Life Care Ambulance Services, which is the EMS ambulance service provider for the area. And then over here, the group I call Core Team. These are the partners that engage in the shared communication and information exchange. This includes our team leader, the Region 3B Area Agency on Aging, an organization, Senior Health Partners. Their services include a lot of prevention things, as well as geriatric mental evaluation. Community Healthcare Connections, which is an agency that does a lot with access for un- and underinsured. Bronson Primary Care and Integrated Health Partners. These are the two primary care networks in the area. And then Grace Health, which is a federally qualified health center. And then in the kind of overall project activities, we also have an agency called Elder Law of Michigan, who does provide some direct services, but then they also have a big role in the state with advocacy and education, supporting and connecting the different community coalitions. And then, of course, Michigan State University. So the CCR service planning, this care model, the coordinated care consists of shared communication, decision-making, and information exchange. Being able to share that protected health information and client data with each other in order to problem solve and decide on service enrollment, and to really streamline service delivery. And this is all enabled, and this is important, by that uniform consent form, which allows for the sharing of protected health information, as well as our custom-built case management system, the platform for delivering this care. We're using REDCap, which, if you're not familiar, REDCap was designed or developed by the NIH. The idea behind it was to be an inexpensive electronic health record system for clinical researchers. That way it would function basically like a health record system, but would collect data in a way that's usable for researchers. We have programmers who worked within the REDCap system to develop our kind of custom system that functions in the way we need it to according to our care model protocol. And so to give you the kind of overview of how the service planning and the coordinated care goals, if you remember, the goal is to increase and support independence and capacity for self-care. So it's a holistic patient-centered model. It's a single point of entry system. Another way of thinking about it is wraparound services, because it meets the needs across all the sectors. It definitely involves community health workers. And then if you're familiar with AIR's taxonomy, and the different categories. This is a list of the different categories of services. And between the partner agencies, they're able to provide a minimum of 61 different services, ranging from things such as meal delivery and financial counseling to skilled nursing care, health insurance navigation, housekeeping assistance. So this is our project case flow. The first step is identifying the older adults who may benefit from the care model, and so this is where our referral partners come in. They identify and refer older adults to the Area Agency on Aging. We are looking for potentially vulnerable older adults, is what we've been training them on. People who seem like they might be at risk for abuse and neglect or have complex care conditions and complex health and social service needs. They're all appropriate to refer. Then step 2, our project manager on this research project is also based as the project manager at the Area Agency on Aging. So we have their staff closely working with us on this project. And so that project manager receives all the referrals. She screens, intakes, and consents. And importantly, consents not just for research, but also that uniform consent is kind of the key thing for enabling the care model. We have to be allowed to share the information in order to do the coordinated care. So for the research side, the AAA project manager, she does all this, enters it all into REDCap. We're seeking to enroll a minimum of 300 persons. After they get consent screened and taked, REDCap automatically randomizes to the standard care or the intervention group. So the standard care group is the standard information referral that the Area Agency on Aging does. This could involve, enrollment in the AAA services as well as information about other things in the community. You can think of this as the slightly more passive approach, whereas the CCR, our intervention model, is the involved, hands-on approach, where you get that coordinated care provided by the core team members, which again, that consists of shared communication and information exchange in REDCap, our electronic case management system, with the goal of promoting independence and capacity for self-care by trying to meet the needs, the broad health, wellness, community, social support needs of these clients across the spectrum of sectors and services. During this process, the AAA is the lead agency responsible for opening and closing cases, and that's because they emerge as kind of the natural team leader for the project during our pilot work. Then that brings us to our evaluation, which I'll talk about in more detail in the slides coming up. So we're going to be looking to see if CCR clients have delayed incidents of repeat emergency department use, as well as elder abuse neglect. We're going to be looking to see the impact, if there's an impact on outcomes depending on referral source. And then our kind of last objective is thinking about how can this model be supported in real-world conditions. So the first objective, examine the impact of coordinated multi-sector service delivery offered by the CCR on our 2 geriatric public health outcomes: elder abuse and neglect and emergency department utilization. So we're taking an experimental, explanatory mixed methods approach to completing this objective. Elder abuse and neglect, we will be using, actually for both of these outcomes, we're going to be using administrative service and billing data. So elder abuse and neglect will be looking at police incident reports as well as adult protective service records. And then emergency department utilization, we will be using the service and billing data. And the reason for this is that there's many ways to enter the system. If you're a victim of abuse or neglect, it could be APS, it could be the police. And we also know that not all victims actually interact with those formal systems, but that victims have a very high rate of emergency department utilization. So this is going to be an RCT design. As I said, they'll be randomized to standard care or this CCR intervention. The quantitative data is going to be used to test the hypothesis that the CCR intervention will delay incidences of abuse and neglect and repeat ED visits for participants in the intervention group as compared to our standard group or standard care group. And we'll be using survival analyses to evaluate that. Qualitative data is going to come from focus groups with participants in the CCR, as well as caregivers when possible. This is going to be to explore whether the intervention effects occur as we theorize. Based on our framework, we're trying to reduce the vulnerability to reduce that interdependency. And so there's not a real feasible, practical way of measuring interdependency during this trial. So the qualitative data will be used to explore that. And if it turns out that there's new pathways that the intervention is successful, but for other reasons, we will try and test these pathways during the mixing portion of the mixed methods. The second objective is to explore which institutions are best positioned to perform integrator roles in connecting vulnerable older adults to the needed medical care, public health, and social community services and supports provided by the CCR. This, again, we'll be using an experimental exploratory mixed methods approach. We'll be doing moderator analyses to examine the impact of referral source on the observed treatment effects. The different referral groups, the first responders, are increasingly having a bigger role in public health and prevention. And so this will allow us to see whether the populations they interact with in terms of vulnerable older adults have the same treatment effects for the intervention. So we can better understand their role as public health practitioners. We'll be getting qualitative data from open-ended surveys with staff and interviews with site leadership to understand the perceived impact of the CCR intervention. And so the mixing portion of this mixed methods, the thematic analysis produced will provide context into why or how certain agencies may be better positioned to be integrators. And then we'll be doing additional statistical modeling, as suggested by this analysis and to the extent data is available. Then our last objective, and this is really our translation dissemination objective, and that's to identify implementation and translational issues of data sharing across the health, human, and civil service sectors to ensure generalizability and successful dissemination. And so at the end of this objective, we intend to create a product which we're calling the Patient Care Record Central Framework, which will be a blueprint, hopefully, for other communities to replicate this. And the best way of explaining this is a metaphor that our friends at the Area Agency on Aging came up with. The reason this project works is because Battle Creek is a small community. The service providers all know each other. They all agree abuse is a problem. They're used to working with each other. And so even though right now we do have a care model protocol that we're using to guide this intervention, it is a community-based project, and to some extent it works because there's trust and innate systems and processes already in place. And so the way our AAA partners put it is that Battle Creek is integrated like a bowl of spaghetti, and what we need to do in this project is to turn ourselves into lasagna with layers that provide organization while facilitating communication with the other partners. And so with such a structure, it'll be easier for others to copy this lasagna recipe or the blueprint we're going to be creating during this. And so the idea for this blueprint is right now we're using REDCap, but long term, this really needs, we'd like it to be an independent system. We'd ideally like the independent system to be owned by the patient and the caregiver, and for it to interact with the other service providers' existing networks. But these are all things we need to explore during this objective. We're trying to create something that supports the care protocol but meets all the practical, technical, logistical, and legal considerations necessary for that to happen. And so this will start with constructing stakeholder panels, including everyone from the service providers to the caregivers, health IT folks at the agencies. We're going to be doing a needs analysis, then follow-up focus groups and interviews, reviews of literature, and policies and procedures. The idea is we want the blueprint to be something other communities can take and adapt as needed to be able to replicate this care model in their communities. So ideally, we intend to have details about parts of the system that's flexible, such as, I suspect, probably who might be the team leader, and then parts of this, this blueprint that's not flexible because it might be related to HIPAA reporting or compliance. So I wanted to give you a quick overview. These are pilot results from the Hartford Action Award project that helped guide us towards this Robert Wood project design. Real briefly, there's 27 clients who went through, and I just want to highlight these kind of positive prevention things that we saw, and that 8 people with prior hospital admissions were in that group. None had been readmitted. 25 improved their self-management of a chronic condition. 6 patients who had type 2 diabetes, 3 had a decrease in their A1C markers, and 2 maintained over a 3-month period. And 6 out of the 7 clients with medication adherence issues are now compliant. And so this really helped us to think about the usefulness of this model, not just for responding to needs of victims, but also as a primary prevention strategy. So I want to speak a minute about how our project integrates with the Systems for Action portfolio. So this project is all about understanding the impact of service alignment and integration facilitated by the electronic communication and data sharing, and the impact of that on our target outcomes. We'll be investigating a novel community-based organizational model for the integration of preventative services across sectors, as well as settings for older adults. We're going to be exploring the integrator roles that different community partners may have as referral sources. And then on the bigger culture of health framework, in completion of this project's objectives, as we develop that blueprint framework for translation of the model for other communities, it has the potential to impact the electronic medical record linkages measure identified by the culture of health framework. So because this is a community project, I thought it important to quickly touch on some perceived benefits to our stakeholder partners, because as you can see, we have a lot of them. On the referral side, for the ED system, being able to ensure care after discharge is of obvious value to them. For our first responder partners, there's likely that this project is going to help reduce moral distress, in that they often go into situations where they see the older adult's home, they see the circumstances, they know that they have service needs beyond what they're there to do in their actual role as a police officer or an ambulance EMS provider. And so having the CCR available and being able to link them to these services helps give them a real active approach to helping community members. On our core team side, there's a lot of different financial benefits to this, expanding client bases and opportunities for increasing billing, especially by working so closely with the primary care networks. There's also conserving resources by really streamlining the service planning and getting this all documented and facilitated on the electronic system. So our project, as I started with elder abuse, it arose out of a need to figure out how to better address elder abuse in the community. But there's a lot of other reasons this project's really timely and relevant to the other partners on our team, as well as I think other communities. CMS is transitioning towards the bundled payment models, and Medicare has traditionally made separate payments to providers, and they argue that this approach can result in fragmented care with minimal coordination across providers and settings. And so since research has shown bundled payments can provide an incentive for working together across specialties and settings, CMS has been rolling this model out. And so in theory, that all sounds great, but as you can see in this quote from Metascape Medical News, the physician, former California Medical Association director, argues that for bundled models to succeed, hospitals and physicians need to tap into a variety of patient data sources, not just the hospital's EHR, and get that information quickly to manage care effectively. And the necessary digital infrastructure just isn't in place yet. And so I think our project, this is quite similar to the problem that we're having in our community with the need to tap into the variety of client data sources. And so this is I think a big, the product we're going to create at the end of this, the blueprint, should be of a lot of help to a lot of different communities. And so finally, some other impact significant things that we wanted to highlight was that the findings from this work will contribute to development of both applicable and reimbursable service models utilizing community health workers. And we anticipate our data will support policy and funding decision making in the state of Michigan, as well as hopefully other places, demonstrating the value of care models that involve community health workers. This will be the first RCT of an elder abuse and neglect intervention, and the first tested primary prevention strategy for elder abuse and neglect. As the goal of the CCR is to improve capacity for self-care and independence, and as you saw with some of that pilot results we found, we anticipate that we're likely positively impacting other geriatric syndromes in addition to the public health ones we're looking at, the abuse, neglect, and ED use. So some project milestones. We're training our referral partners mid-September with the goal of launching our RCT October 1st. Our data collection for the qualitative strands begin approximately January 2017. We anticipate having some preliminary analyses done in summer of 2017, with the final analysis being done in the last quarter of the project period. And as part of that final analysis and the final narrative writing, we're not exactly sure, I guess, what the product, that patient care record central framework blueprint is going to look like, whether it be a white paper or a toolkit. But we have plans to disseminate that broadly by going to different elder abuse coalitions in the state, the Area Agency on Aging network, sharing that out through there, as well as different venues for researchers, practitioners, such as conferences, publications, and platforms such as the Robert Wood Johnson website we have. Oh, which good is the next slide. So project updates, I've been told, are going to be put up here on our project website. And now I think it's time for the commentary.
Exactly, and I would just like to encourage folks, as you hear about these studies and they pique your interest, to visit the project pages on the website. As Carolyn just mentioned, as products become available as dissemination products, they might be slide presentations or other pieces that are emerging from the projects, become available and are cleared for placement on the website by the investigators. You'll be able to follow along with this research as it's being conducted. These studies, these individual research projects, and indeed the CRCs are also very early in their funding cycles. So this is really exciting to hear about the work that is getting underway, and we look forward to following it throughout the life of the project and after. And with that said, it is time for the commentary, so I'd like to introduce from one of those collaborating research centers, Ruth Coffman, who is Executive Director of Health Labs at the University of Chicago Urban Labs and is a co-investigator on Chicago's S4A Collaborating Research Center. So Ruth, take it away.
Thank you. Thanks a lot for that fantastic presentation. I think it was incredibly interesting to hear about the CCCRT and what is happening in Battle Creek. I have loads of thoughts and questions, but I guess one of the things that I thought was particularly interesting that this project sort of aligns, or that this project sort of highlights about the S4A research agenda, is just the sort of, I don't think it's necessarily attention, but how thoughtful these interventions need to be in terms of system alignment in order to do the kind of proper care coordination and organizing of information that's needed in order to align the systems, without adding sort of an extra layer of an extra layer that either a patient or somebody working on behalf of the patient needs to navigate. And I think that this intervention kind of exactly does do that. So it seems to be very thoughtful about, so for example, the sharing of information via this electronic health record, or this record that you guys are creating, seems to me to be exactly that. So it's attempting to kind of bring together systems without adding an extra layer of bureaucracy. And I think our project for S4A, the Comprehensive Care Community and Culture Program, is very much about trying to provide comprehensive care for patients without necessarily adding care coordinators, right? So we try to kind of reduce the number of people involved in a patient's care, with the hope that if sort of one person is kind of owning the problem and has the relationship with the patient, that the patient's outcomes will increase. And so hearing about this program was really interesting for me, because I just had a bunch of takeaways about how to sort of add more information or bring together systems, and again, without sort of increasing the burden. So that was one of the things that I thought was really interesting, and I think I'm going to just watch going forward as we learn more about your results. Some of the sort of questions or some of the things that kind of popped up for me in thinking about kind of the specific intervention in elder abuse was just our experience with the patients that we've been working with, who are sort of all high utilizers of emergency rooms, pretty vulnerable individuals, low income, majority African American on the south side of Chicago, is that, and who, many of whom actually we have incidents of elder abuse. It's just that we have found it sometimes useful to sort of add additional caregivers into the relationship. So as you guys kind of pointed out, and as kind of, I think, assumed in the preventative model, that, you know, elder abuse is often just kind of a result of one caregiver sort of being completely overburdened or overstrained or kind of unable to take on the care of somebody with probably, you know, complex social and health care needs. And so obviously the more kind of support and independence and capacity for self-care that that individual has, the less likely that abuse will take place, and that seems to me to be very reasonable. But another thing that we've found is just that oftentimes in these cases, if the number of people who are personally involved, the number of informal caregivers in a patient's life is increased, or if other people are kind of added to that mix, that can also provide kind of like an alleviating set of resources, or just kind of other relationships can enter in and sort of help that out. And so I just wanted to kind of offer that as you guys are moving forward towards your implementation. And then the other thing that I just wanted to comment on, because I know I don't have a ton of time, is just I really liked the mixed methods qualitative piece of the intervention in terms of trying to identify what part of the CCCRT is sort of working. So once you get these kind of broad outcomes in emergency room utilization and elder abuse and neglect and you know, occurrences, so hopefully those will be going down, but then to figure out kind of what piece of the team, or maybe it's the whole team, or what part of the referral process or the origin of the referral is sort of maybe moving the results the most, I think is really a fantastic addition or part of the study, just because I know from the work that we do here at Urban Labs, where we're sort of, you know, we find and test promising interventions in the hope that they will scale. The issue when you want to scale something is always like what part of the program is actually working and for whom. And so if you do a randomized controlled trial and you haven't kind of drilled into sort of the finer components of the intervention, as it seems that you guys are doing, then it makes it really hard to like translate and disseminate those results. And so I was just really, really pleased to see that piece. And so I think, yeah, I'll stop there. I mean, I think I'm going to be very interested to see the sort of preliminary and final results. And I'm just happy to hear about what other questions other folks have.
Thank you, Ruth. Before we do get to questions, and again, as you're thinking of questions, please type them in that chat box on your screen. But as those questions are coming in, I wanted to ask Carolyn if she would like to reply to anything Ruth said in her comments.
Yeah. So. You mentioned about alleviating or involving others in care and having that alleviating set of extra resources in hands. That is something we're trying to do in the care model. And so one, that's by bringing in other services as a leading set of resources. So it's a patient-centered holistic model. So to the extent that the patient wants other involved in their care, that is something that the services and our care coordination aims to do and strives to do.
Excellent, thank you. We do have some questions in the chat box now. The first couple are related to community health workers. You had mentioned, Carolyn, early in the conversation about the CCCRT, the importance of community health workers to this work. And the questions really revolve around how many CHWs were involved in the pilot project, and what were their functions, and really in the overall model of what is the role of the community health worker?
Yeah, no, that's a really great question. I'm glad you asked. For context, this Battle Creek is a smaller city, so for the number, we have one at the moment. So at the Area Agency on Aging, I said that there's a project manager. The project manager Bonnie, our AAA Wonder Woman, does a variety of roles, but she is a community health worker, and that's project manager and kind of the team leader for the different cases. She does the intake, the screening, the initial service planning and referrals to the other agencies, and does a lot of hands-on work. Not that the other agencies don't, but I know she particularly does a lot of the hands-on kind of service planning and work with the clients and their families. And so the reason there's one is because there's one. We're trying to, I believe the AAA is working on hiring a second person, and I think to the extent that the need for the services grows and the ability to reimburse them, there's certainly, I mean, as far as the number goes, I'm sure they can use way more than two. But so I hope that answers your question. Her role is not just our project manager on the research, but she's also, case manager, we can call her, for the care coordination.
Thanks, Carolyn. Another question that we have from a viewer is in some communities, emergency medical services often make runs to elders' homes on calls that are not really emergencies. Has your group tracked the impact of these calls and looked at the possible reduction of non-emergency response calls?
So another great question, and the answer is we'd like to. I know both our EMS provider has brought this up as they think this will impact that, and we agree. And we are working out the details of how we can do that with the way their data works.
Excellent, thank you. Another question relates to the collaboration piece of this research. Obviously, the study is looking at alignment, novel mechanisms for alignment, but an area of interest and concern, obviously, within the research agenda for Systems for Action is cross-sectoral collaboration. And I'm really interested in if you can talk us through a little bit more of that process of engaging those referral partners. How did that sort of get underway, and how were those stakeholders, not only among the referral partners, but also in the CCRT team, how were they brought together and sort of the genesis of this collaboration?
Sure. That's a really good question because it had nothing to do with me or the research team per se. It is the Area Agency on Aging and the wonderful work they do and the wonderful work that Bonnie, that community health worker, project manager, all around Wonder Woman does. They have a lot of respect in the community. They're very good. As I said, they emerged in our pilot work as the natural team leader because just the staff there is really great about building bridges and working with others. And so this was all, as I said, it's really very much a community-based project. This is community-driven, and they were really instrumental in identifying appropriate stakeholders and networking and getting our additional stakeholders and bridging those cross-sector alignments.
Excellent, thank you. And I think from the Systems for Action perspective, I just want to underscore that word action in the Systems for Action National Program, and having that kind of stakeholder involvement early and even preceding, in this case, the study development is really integral to ensuring the real-world relevance and adaptability. You talked about the blueprint and your plans for dissemination and translation in the future, and really having those kinds of multi-sectoral partnerships informing the research from the beginning is so important for that action piece. We do have another question about whether your team has had any discussions with insurers about how the model might be sustained.
With insurers. As I said, we were hoping to impact funding and policy decisions about models using community health workers. CMS will allow for preventative services to be reimbursed when they're administered by community health workers if recommended by physicians, and so that's why we were really excited to have the physician, the health system stakeholders, those primary care networks, join the team so that if we have clients that belong to their practices, we can work with them on that. As far as private insurance agencies, we have not, but that's a really good point and something we need to put on our to-do list as this project moves on.
Excellent, thank you. We have a set of questions that relate to medical provider time spent with patients. And the questions are really, does the intervention involve any change in time spent by physicians with patients? If so, in what direction is that, and how is that being affected? And are you measuring and assessing the intervention and non-intervention arms in terms of provider time with patients?
So no, not with the physicians. Their role in the project, as I mentioned before, so if we have their clients, they can, we can work with them on the shared communication. They can be in the system. As far as then on their side, we're not at this point measuring that, but that's an interesting idea for the future because we really saw this is a project for the community-based providers. And obviously, everyone needs to network across not just the sectors, but the settings. So the emergency department, primary care, as well as community is all working together in this. But for now, we were really focused on this as a model for the community and the community agencies.
All right, thank you. Looks like we've got one more. When will focus groups be conducted and who will participate? I think I saw the qualitative arm of that starting in winter.
Yes. There's two, so both objective one and, let me think, objective one, all three of the aims have qualitative portions. For objective one, the focus groups, the intention is to understand the mechanisms by which the intervention is working, to see if it's working as we hypothesized according to our framework or if by other routes. And so those focus groups are going to involve participants who were in the CCR, who have had gone through the process and have had their service enrollment. We're trying to give it, I believe it's about 6 months out, so we really can get the time between when they first showed up and a few months later. If family members or caregivers were involved in the care, we're going to invite them too. To be in the focus groups and tell us about their experiences with the intervention. Then there will also be, in that kind of third objective, our blueprint building, there will be more focus groups, and so that will involve a stakeholder panel, which includes the stakeholders we saw on that chart, but as well as patients, families, caregivers, older adults in the community. To get a really well-rounded approach. And then also within those partners, not just the site leadership and staff members, but we're also, we need everyone from IT to the privacy officers, because there's a whole lot of moving parts in building a system like this. Beyond just does it do what you need it to do, it needs to be done in a way that's compliant with HIPAA and with reporting and data sharing, storage, retention policies, which don't always work together the way you think they would.
Thank you so much, Carolyn. And I want to remind folks before we wind down this portion of the call to visit that project update page on the Systems for Action website. Bookmark it, if you will, as new emerging findings become available through various dissemination channels that Michigan State may choose to use. We will make sure that those pieces are included in the products and the emerging results. We also will be obviously inviting Carolyn and her team back again a little later in their study to share some of what they're learning, and we're really excited to do that. So I would like to thank very much Carolyn Pickering and Ruth Coffman for their time on today's call. I'd like to remind folks of upcoming webinars and events. As you heard today, with the focus on elder abuse, and then in last week's call, focus on the probation population, we are looking a lot at some vulnerable populations in these independent research studies, and how systems alignment can improve the culture of health for those populations. And we have a couple of webinars coming up on our other two independent research projects that are individual research projects that are looking at vulnerable populations. We're looking at housing to homeless high utilizers of healthcare services with the Los Angeles County Department of Public Health Services in our next webinar, September the 14th. Coming up September the 21st, we're going to be looking at the impact of integrating behavioral health with temporary assistance for needy families. That is our investigative team at Drexel University. We hope you'll be able to join us for those. Again, the slides for this webinar will be circulated among registrants after the call today. And the last week's research from the University of Delaware that was highlighted in last week's webinar is available online and archived as we archive all of these. So we are so grateful that all of you have attended and you find this work as interesting and important as we do here at the National Coordinating Center. This is our contact information. By all means, please let us know if you have questions or concerns, or if you need to get in touch with some of the researchers that you've heard speak. We will continue highlighting not only these individual research projects, but also we'll be hearing from, as we did today, our collaborating research centers on these calls as well. And then a little later in the year, we'll be hearing directly from the collaborating research centers about projects they have underway. I want to thank our team at the National Coordinating Center, especially Ann Kelly, who worked so hard to make this webinar series happen. And once again, many thanks to Carolyn, Pickering, and to Ruth Coffman for a terrific presentation. Thank you, everyone, and have a terrific day.